Good afternoon. Welcome to the first international webinar of 2022 organized by Vets and Clinics by Advance. My name is Alba Martos and I'm the International Vet Manager of Affinity. I hope you had a happy entry into the new year, and for those of you who are connecting for the first time, I encourage you to subscribe to the channel to be aware of all the webinars that we will have during this year. Today we meet Luis Feo. Good afternoon, Luis.
Hello, good afternoon, Alba.
He's a European diplomate in internal medicine, and he's currently co-head of the Department of Internal Medicine and Oncology in the Arts Veterinary Hospital here in Barcelona. And today we will address the key aspects in the diagnosis of canine urolithiasis, one of the most common diseases of the lower urinary tract in dogs, as well as being a very frequent problem in the daily clinic. Take advantage of this webinar to ask the questions you have. You can write them on the chat you can see here in the webinar on the right side of the screen. Uh, in case we don't have time to answer all the questions, you can send them to the email address that you can see below in the description of this webinar. On the other hand, remember that you can download the presentation clicking on the link that you can see below here in the description of the webinar. Well, I will not delay any longer and we will start the session. As I said, we are going to talk about urinary stones in dogs. And well, Luis, the first thing is that if you can tell us why do you think that it's an important topic to talk about that?
Well, first of all, I want to say thank you very much for inviting me here. It's a pleasure for me to be here with you. And I think that urolithiasis is like a really common disease in the clinical practice. So I think it's interesting to talk a little bit more about that. And I hope with this question we can have a response about many of the problems that we have in our clinical practice every day. And I hope that you find these questions useful for your clinic and for your daily practice.
So, well, Luis, to have a global picture, can you tell us which are the most common uroliths that we can find in dogs?
Yeah, if we go to the presentation, so and we think the prevalence of the urolithiasis in the global world, probably the calcium oxalate and STRUVITE are the two more frequent uroliths in the world. However, there are some difference based on the location, so probably it's not exactly the same in Spain compared to UK or compared to other locations, but probably calcium oxalate and STRUVITE are the two more common everywhere, and the different presentation will be based on the location, but other less common stones or calculi or uroliths are urate, cystine, and XANTHINE. This is a paper from Spain, but actually there are papers from everywhere in different parts of the world, and probably, but the common things in all the papers are the calcium oxalates and STRUVITE are the two more common. I think there's some important information about the general predictions about the composition of urolithiasis in dogs. So their distribution according with the composition is similar for uroliths in the lower urinary tract, the bladder, urethra, and upper urinary tract, so nephroliths and ureterolithiasis. And that's a little bit different compared to cats. So I think it's very difficult to predict. Probably it's 50-50 compared to lower to upper. But what we know is like for female, the most common affected calculi are STRUVITE, even in breeds predisposed to calcium oxalate, with the exception of two breeds, the Dalmatian, what we are common seeing urate, and the miniature schnauzer, where calcium oxalate and STRUVITE are equal proportions. But I think like the breed predisposition that it's crucial in males. That's why I recommend to many of the clinicians to have one of these tables that you can find in some articles about the different predisposition based on the breed. So, for example, if you go to English Bulldog, the most frequent urolith that you can find it's urate or cystine, or if you go to a Stanford Bull Terrier, the frequent male predisposition is 16. So I think this table it's quite useful to know what is the most frequent stone that you can find in every single breed.
Thanks, Luis. Now that we have this global picture, I would like to start to talk about the tests that we can use to diagnose this urolith. So, a widely known is the urinalysis, and I would like to ask you how important is this test to diagnose the different stones that you can find in dogs.
So I think that the urinalysis is very important. I think like it's very, very important to complete a complete urinalysis. And when we think in a complete urinalysis, sometimes we forget they have different parts. The parts are you here have here in the blue part of the screen. So color, urinary specific gravity, urinary distich, and sediment to check if we have a with and without staining to check the bacteria, to check the crystalluria. Saying a few things about the urinary specific gravity. So it's very important when monitoring urolithiasis. I think it's very, very, very important to check the the evolution of this urinary specific gravity, and we know that it's not affected by storage methods, and that's important. One of the things that's not is not affected. Also, it's very, very important the pH when we think in urolithiasis. And we know that probably in dogs, if you have a pHimeter, it's better than only the urinary distich. But I mean, sometimes we don't have this device. It's enough with the urinary distich. We know there is a 0.5 minus delayed or alteration compared with the pHimeter. But one important thing about the pH is when we have a pH less than 7, it's more likely that you have a calcium oxalate, you have a purine, or you have cysteine. And if you have a pH more than 7, it's more likely that you have STRUVITE. So I think probably these are a general picture of the pH. I tend to use these 6 rules when we think in urinalysis and urolithiasis that I think are really kind of useful in your clinical practice. And we will talk about these 6 rules now. So the first rule is that I think it's important, and probably one of the most important ones, is that crystalluria does not confirm the presence of urolithiasis, because sometimes we tend to change the diet only based on the crystalluria, and I think like it's not exactly the same. Also, a second rule that I think it's important is that the presence of crystalluria will not necessarily lead to the formation of calculi in the future. And this is very, very frequent with STRUVITE and calcium oxalate. It's not going because you have crystalluria, it doesn't mean you are going to have a stone in the future. Also, sometimes I think the rule through the rule 3, sorry, is that sometimes you find urolithiasis in the absence of crystalluria, and because one of the stone has formed, it is thermodynamically more favorable for minerals to deposit in the surface of an already formed stone than to form a new crystal. That's why sometimes we have in the radiographs or in the abdominal ultrasound one urolith, but you don't find crystals, and that's important to remember. The rule 4 for me is that although crystalluria sometimes predict the composition of the stone, this is not always the case. And that's very, very common when we think in calcium oxalate and STRUVITE. Sometimes you have a stone of calcium oxalate and the crystalluria is STRUVITE. So you have to be careful about that. It's not always correlated. That's important. The rule 5. The rule 5, I think it's interesting that the presence of crystalluria might lead to the vet to investigate. So sometimes the crystalluria is more important. And I think in these cases are cysteine, urate, and xanthine. The presence of crystalluria in these 3 situations are probably more important compared to the other ones. And the last rule is that the time and temperature are important. That means like a temperature change might cause crystal to form in the urine, which result in false positive crystalluria. That's why it's very important to examine the urine when we're thinking in crystalluria in less than 60 minutes. Actually, as soon as the better, probably.
Thanks, Luis. So now we have a global picture about urinalysis and how we can manage it, let's move on imaging tests. So how we can use this imaging test or the imaging test that we have available in the clinic to diagnose URLITHs in dogs. Can you give us your opinion, your experience?
Yeah, so I think that the imaging tests are really important, and for sure to everybody, the chest radiographs or the radiographs, abdominal radiographs are very, very important. And one little thing that I think always we need to remember is that the radiopack calculi or uroliths are calcium oxalate, calcium phosphate, silica, and struvite. And however, the radiolucent that you are not seeing in the with a regular radiographs are cysteine, urate, and xanthine. And I think that's very important to remember, because sometimes when we're thinking in the stone, you always do a radiograph and you think, okay, that if it's not in the radiograph, it's not there. And that's not true, because we know that cysteine, urate, and xanthine is they're not. You are not going to see these stones in the radiographs. There's a few exceptions. If the real radiolucent calculi is more than 5 millimeters, might be detectable on radiographs. It's not always the case, but sometimes. And the opposite situation is that you have a radiopack calculi less than 2 millimeters, might be hard to see in radiographs as well. So I think it's very important to remember which one are radiopack and radiolucent on the radiographs. Also, it's very important to take correct radiographs. So as you can see in the radiograph on the left, this is a radiograph of the abdomen, and sometimes we miss to introduce all the urethra, and there are many calculi or stones that you can find in the urethra. That's why it's very important to do a second radiograph, as you can see in your right, where maybe you can have a urolith on the distal part of the urethra. So I think it's important when we are doing radiographs for uroliths to put in the radiograph complete urethra. And sometimes, because sometimes the calculi or the urolith is there. Also, I think it's very important to perform radiographs pre-surgery and post-surgery. This is one of the cases that we have 2 years ago, where it was a calcium oxalate full urolith in the urethra, and I think it's very important to perform radiograph before and after, because sometimes you can miss some of them in the surgery, and this is, for example, the radiographs after surgery where we don't have any, but sometimes we miss some of these calculus. So I think that's why it's important to be sure that we don't miss any calculus in the surgery, and we don't have to go back. For sure, the abdominal ultrasound is very important when we think in uroliths. Obviously, in abdominal ultrasound, you can see to identify radiopack and radiolucent stones. However, we have to think that we are sometimes missing some uroliths in the urethra and ureters only with the abdominal ultrasound. So it's important sometimes to combine radiographs and abdominal ultrasound. And also, it's sometimes very important to combine with other additional tests, that is the contrast imaging with the contrast imaging of the urethra, as you can see in the radiograph. It was a cysteine calculi here, or with we have what we call a retrograde contrast, or sometimes it's less frequent, but sometimes we use that as well. The upper or anterograde pylography, that is putting the contrast directly to the renal pelvis, and we can see a little bit better the ureters.
Thanks, Luis. So, well, now that we have seen the diagnostic methods that we have, how we know that we have correctly evaluated the uroliths after diagnosing them?
So I think when we you have a this, I think it's a good question, because we have to take in mind that there are different based on the urolith composition. We classify the urolith in a different way. So when we think a single mineral urolith, it's it's a urolith that contains at least 70% of a single mineral type, and that's probably the most frequent situation in your clinics. However, you have to think into other options. If you have a compound urolith, is a urolith with who needles and layer are formed with different minerals, and we will talk about this a little bit later. But this is important. It's very very important to differentiate between the needles, the stone, and the shell. Also, sometimes you can have a mixed urolith. The urolith contain less than 70% of a single mineral component with no obvious needles on crash. And this mix, probably you have two different compositions, and you have to focus in these two different compositions. And that's kind of classic with calcium oxalate and calcium phosphate. But talking a little bit more about the compound, about the needles. So the needles of a urolith are is the area of obvious initiation of urolith growth, which is not necessarily the geometric center of the sample, as you can see in the picture. But in general, the mineral type in the needles layer should be the primary focus of prevention measurements, because the needles is the area of where everything has begun. So if we have a needles from, for example, STRUVITE and a stone of calcium oxalate, our we need to focus on the needles, thinking in the medication, thinking in the diets, and that's very very important to know after you have removed this stone.
Okay, so now once we have already detected the stone and we know its composition, what do you think about the most appropriate way to eliminate this stone or these stones?
So I encourage everyone to read this ACBM small animal consensus you can see in the screen. It's free online, so you can check. There's a lot of. It's very very good because they have all these different recommendations based on different type of urolith and also all the different options that you have. But I think when we have a stone or urolith, we have different options. For sure, the medical option, it will be very effective in estrobite, allopurinol-induced xanthine, and cysteine, and is clearly less effective in urate. For sure, even though there is we have estrobite or allopurinol xanthine, if we have an urethral obstruction or a very very large stone, probably medical dissolution is not an option. But for sure, I will say that the struvite is for sure one of the biggest ones that we need to think in medical dissolution. Obviously, there are other methods, but I will say the basket extraction using cystoscopy is also a good one, an important one. The problem is you need to have all these devices in your clinics that are really, really expensive. But if you want to think which patient it's a good candidate for this, you have to bear in mind that the stone must pass through the urethra. So even if you take these stones, it should be probably usually stones less than 4 millimeters, but obviously depend on the size of the dog. And it's easier to do it in females compared to males. Intracorporeal lithotripsy, that is something that is kind of popular in these days. In males over than 6 kilograms with no more than 3 stones, probably is a good candidate. And the stone has to be between 4 to 7 millimeters. In females, for any side of stone, you can use it, and for all urethral uroliths. I have to sometimes it's contraindicated if you have a very large stones, because maybe you need to do more than one sessions. But if it's tiny or really small uroliths, I think it's a good test, a good way to remove these stones. Also, the percutaneous cystolithotomy or the classic surgery, I would say in males with more than 3 stones. This is what I recommend, with more than 7 millimeters of size, or if lithotripsy is unavailable, or in female, almost all the stone can be managed with lithotripsy, but sometimes due to the money constrictions, we tend to do this technique. But I think it will be depends on what you have in your clinics. I think it's reasonable to do a percutaneous cystolithotomy in most of them if you don't have all the other techniques. And for sure, medical dissolution when we think it's necessary. Actually, we will talk a little bit that later because we will talk about all the different calculi. So we will talk more about the medical dissolutions.
Yeah, in fact, Luis, thanks. But in fact, we are going now to start to dedicate a little bit to each of the stones you mentioned at the beginning of the presentation. And we will start with the most prevalent ones, the struvite stones. So can you explain us which are the main aspects of these stones?
Yeah, for sure. So yeah, struvite for sure. For me, I think is one of the most frequently one we already mentioned. Is the magnesium ammonium phosphate calculi, so we call struvite. And what we know is that the bacterial infection, urate positive species, not all of them, only that ones, play a role in the pathogenesis. For sure, the bacteria that we need to think is Staphylococcus, Enterococcus, and Proteus. For sure, are the most common bacteria involved in this urolith, and is clearly much higher prevalent in females because we know the females are more frequently affected by UTIs. That's why. So you need to have this combination of infection and probably other factors like a much higher amount of magnesium and ammonium. So regardless of the size of these calculi, the number of locate or the location, as long as they are not obstructive and they are bathed in urine, they can be medically dissolved, as we already mentioned. So what are the general recommendations in these cases? So for sure, it's very, very important because we will tend to have an infection in most of the cases, antibiotic therapy. I always recommend to do a urinary culture in these cases because you need to know exactly which bacteria you have and if it's resistant or not to some of the frequent antibiotics that we use. So, based on the recommendation, obviously antibiotic therapy is one of the biggest. Also, promote urine acidification with a pH not generally less than 6.5, and we do that with suitable diets that also minimize the intake of certain minerals like magnesium and phosphate. Also, another strategy that sometimes with the diet is enough, but another strategy that you can do is an increase in water intake to be sure that you have a urine specific gravity less than 1020 because you want a urine really diluted. Also, sometimes recommend, and I think in females are kind of useful sometimes when the urates are small, is more wax to increase mobility and elimination of the stone and crystals. So what we need to, some interesting things about this dissolution of these strobites. So excessive acidification can lead to the formation of calcium oxalate. So you have to be careful about the excessive acidification. And also, you have to be patient because it can take 1 to 4 months to eliminate these strobite calculi. And one big rule that we have been using these years about the antibiotic therapy and the specific diet is that we should maintain this diet further than 4 weeks after the stone has been eliminated. And this was the recommendation since the last consensus. I'm being honest with you. I still recommend this because I think it's more useful. But you have to be in mind that after 4 weeks, everything is resolved. You can try to remove the diet and to remove the antibiotic. As I have mentioned a second ago, I think it's very interesting the guidelines for the diagnosis and management of bacterial urinary tract infection that you can see or you can have online free, and they have changed a little bit the management of these strobites. So one of the recommendations they do, and we tend to do always like this, if your urinary culture it's negative, I will recommend to perform a culture of this of the calculi. The two samples might also have different bacteria. That's why I think it's also very important to many times to culture the stone at the same time that you do the urine. The choice of antibiotic or which antibiotic I use for the beginning of before we have the urinary culture results. So I will recommend amoxicillin clavulanic or TMS or trimethoprim sulfate. This is one of the biggest changes they have proposed in these guidelines. They recommend short antibiotic therapy of only 7 days. Probably for me it's too short, but this is the recommendation they give us. I say that I'm more 3 to 4 weeks and not only 7 days, but I think that it could be an option if the solution does not progress satisfactorily. So in these cases, when you started this treatment with diet antibiotic and you still have the urolith with the same size, you need to repeat the urinary culture and treat again infection if you have a recurrence, or maybe think that maybe you have a mixed composition stone that you need to remove it, not only medically um, um, or you will not have a medical dissolution of this stone.
Thanks, Luis. So now we have been talking about struvite stones, we can move to the second most prevalent uroliths that are those ones from calcium oxalate. So which are the main aspects that you can tell us about these stones?
Yeah, so the two most important factors involved in the formation of calcium oxalate stones are the urine supersaturation with calcium and oxalate. So this urine supersaturation is probably the main factors, and also the balance between the promoters and inhibitors of the stone formations. These clearly are the two main factors. Obviously, there are other factors involved in the pathogenesis of these stones, and is the low pH probably it's less important, but it's also important to promote the formation of these calculi. So just to briefly mention that an accurate measurement of supersaturation is the RSS or relative supersaturation of urine that you can find in some of the diets. They give you a value that is probably useful. And this RS or this relative supersaturation of urine index is calculated by introducing urine pH and the concentration of 10 solutes into the compare algorithm. I don't think that you need to know much more details about that, but it's important to remember that because in calcium oxalate, I think it's probably a little bit more important compared to the other ones. But actually, it's important in all the stones. What we know about the calcium oxalate is when a calcium oxalate urolith has formed, it cannot be dissolved. So it's important that remember that because we need to remove this calculi if we have any problem. So patients showing the clinical signs associated with the calcium oxalate stone, it must be removed using the method described before. So some of the methods sometimes are surgery, sometimes could be lithotripsy. It will be depend of the case. So the primary medical goal is prevention. Prevention is the important thing in these cases. After you have removed the stone or after you have um, treat this patient with surgery or with any other technique, you have to focus on prevention. Um, what are the recommendations about prevention? No? How we prevent after you have removed these stones from the patient? So for sure, one of the biggest one is reduce urinary specific gravity. There are different strategies for that, but increased water consumption probably is the biggest one. And avoid acidification of urine. It's probably less important, but it's also important. Avoid food that increase calcium oxalate formation. There's some food that probably that are more prone to this formation. Also avoid an excessive amount of proteins in diet. And if you have hypercalcemia, you have to control this hypercalcemia. And you have to look why this patient have hypercalcemia. The problem with that is this with these prevention strategies that are based probably most of the time on diets and increased water, the recurrence rates is very, very high. It's up to 53%. So, so there is not prospective studies comparing diets of different with different types, but I think there is a field where is further research into the etiology it's necessary. So I think like we need to investigate a little bit more to know exactly how to prevent this formation. And we need to know that around 50% of the cases, even though that you are doing everything that you can, it will recur. I tend to show these two tables to owners, because if they are using a commercial diet, you don't. So it's okay because you already covered this part. But if they're giving human food, my recommendation is to have these two tables to avoid some type of food that maybe are worse, or maybe have more dangerous, to have more recurrence of the situations. And I tend to print these two tables and show to the owner and give it to them if they're given human food, to be sure with type of meat, vegetables they can give without having a more calcium oxalate prevalence. We have this for the food that they can give and the food they should avoid, and I think this is sometimes is useful for them.
Thanks, Luis. Then let's move now to the third kind of stones, which are those ones uh, with, well, that they are called cystine stones. So can you give us the main tips for them, please?
Yeah. So cysteine is the next stone, or the next calculi that we're talking now. Is clearly less frequent. What we know is a defective tubular reabsorption of the amino acid cysteine in the kidney. But however, other amino acids are so involved in this disease. Sometimes you can see decreased ornithine, lysine, and arginine, but we don't tend to measure these ones. It's clearly, in most of the cases, hereditary and has been associated with different mutations, as you can see in this table from a paper from 2013. So most of the time, we know there is a congenital or hereditary disease, with a genetic involvement. However, in one of the type, what we call type 3, it's androgenic dependent. So we know it is more frequently affected male and non-castrate. So we have, for one part, genetic involvement, and for a different part, a sexual hormone involvement. Um, you have here some of the breed, but I think sometimes you have other breeds that can be also affected. What we know about cysteine is usually affect the lower urinary tract. In dogs, it has been associated with hypercarnitinuria or hypertaurinuria. So these amino acids are decreased in some dogs, and maybe sometimes can cause dilated cardiomyopathy. This is not the most frequent situation, but sometimes can happen. So the question in these cases is how we manage this patient with cysteine. So I think surgery should be considered if the stones are in the urethra. If they're not immersed in urine, so we tend to recommend mechanical extractions. And also when always, but that's not only with cysteine. I think it's with every single calculi that you have. If there are any clinical signs of obstructions, I think you should not wait to try to medical dissolve this stone. So what are the dietary strategies? So the dietary strategy is based on increased water consumption, limiting protein intake as well, with low purine diets, limit sodium intake, and alkalinized urine. And actually, there's some specific drive with low purine diets. that you can use to arrive to desire with to try to 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 complete solve these cases. You have here in this table what are our goals: a pH more than 77.5, urinary specific gravity less than 1020, and you should not see cystine crystals in the urine when you are doing a good job. Definitely, there are other options, medical options that you can use in combination with the diets. But for example, Thiola, that is one of the options, is a cystine chelant or chelating agent and more effective in dogs. We don't have in Spain, but you can have in United States or other countries. Potassium citrate will be also helpful to change the pH. And as already mentioned, my recommendation is to the castration to every single male, entire male, because we know there's some papers, as you can see here in the screen, showing that probably if you you have a more prevalent cystine, even you have a more prevalent cystine formation in the entire male dogs. That's why if you castrate these dogs, most of the time you will have a complete resolution of the situation based on my experience.
Thanks, Luis. So, well, it remains for us to comment on the urate stones that they have a different etiology. So, what can you tell us about these stones?
Yeah, so when we talk about urate, um, so there are two different diseases, I will say. Common to both disorder is the ineffective transport of uric acid with the hepatocyte. However, there are two different diseases. So so some of the patients will have hepatic portosystemic shunt or a severe hepatic disease. And probably in these cases, you need to focus on fix the problem that you have in the liver. And the other, probably the more common situation is when you have a uric acid transport disorder encoded by one of these genes. And this is the common scenario in Dalmatians, English Bulldog, and Black Russian Terrier. So, as already mentioned, these are the two more frequently breed affected with this genetic problem. They tend to present with an average age of around 4.5 years, so they are adult males most of the times, much more than females, probably due to the anatomical difference, but probably there are other factors. And most of the cases involve multiple stones in the bladder or urethra. This is the most frequent location. Um, but it's interesting to remember that a prevalence of the upper urinary tract of up of 46% has been reported in cases of sorry of portosystemic shunt. So in cases that you have a liver disease, you will have around 50% of the cases in the upper urinary tract. So how we manage these cases? So urate stone cannot be dissolved in dogs and cats without uncorrected hepatic vascular abnormality. So it's important that if we have a hepatic problem, you need to try to fix this problem before. However, it's reasonable to assume the correction with the shunt might lead to a spontaneous dissolution of urolith. I have already mentioned that. However, not every time this is working. So, because sometimes you have only, for example, a vascular problem, a shunt that you fix, but you still have a microscopic shunt. And even that you fix this problem, the hepatic problem, sometimes you still have urate stones in the urinary tract. The medical treatment for dissolution and prevention in cases that you don't have vascular abnormalities or vascular hepatic abnormalities are based on these three things. These low purine diets, I think, are quite effective with alkalinating agents and diuretic ingredients. Allopurinol is also an effective treatment, and potassium citrate. These are the three strategies to manage this medical the medical way. So there's some specific diets recommended in these cases. Commercial diets quite effective, so I always recommend to do that with these commercial diets. However, we know that's not always really, really effective. We know this in this. There are some articles they mention that you can have a complete resolution of these uroliths with diets and allopurinol in around 36% of the cases. Sometimes in around 32% of the cases, you have a partial dissolution. And in around 30% of the cases, you don't dissolve these cases only with a medical treatment. So that's why sometimes you need to think in surgery. So in patients with no clinical signs, I try medical dissolution. In patients with marked clinical sign or obstruction, remove the urate. And that's not only for urate, that's for every single patient that you have with urate.
Thanks, Luis. So now, just to finish the webinar, let's move to the last kind of stones, which are XANTHINE stones. So, which are the main characteristics that we have to know about this kind of urolith?
So yes, so XANTHINE I think is one of the biggest uroliths that it will be depends a lot if you use allopurinol or not. So there are many countries like UK or USA where they don't tend to use allopurinol a lot. So that's why um, they don't have a lot of these stones, because we know that almost all XANTHINE urolith and xanthinuria are associated with allopurinol. So especially if you are not giving low purine diets, because the primary xanthinuria in cats and dogs, it's really rare. There are only a few papers talking about that, and it's only frequently seen, or it's more frequently seen in Cavalier King Charles Spaniel. So, but if you, like here in my country, we have a lot of leishmania, so we use a lot of allopurinol, and we tend to see this urate quite often. There are not many information about that, but there's this nice paper from the University of Barcelona found that around 13% of the cases with leishmania that you are giving allopurinol will develop a xanthinuria, renal mineralization, or urolithiasis. And that's very important, because that means, like, when you are using allopurinol, you need to follow this patient properly, because sometimes they can have a really severe clinical signs. Around 50% of the cases with xanthinuria or urolithiasis due to the due to xanthina will develop clinical signs. And also, it's very interesting because xanthinuria can appear between 3 weeks and 9 years after starting the treatment with allopurinol. So it's very important to every time that you are giving allopurinol, you need to have a plan to monitor this patient. These probably are one of my recommendation in cases that you are having allopurinol, you are giving allopurinol, and you suspect that this patient could develop xanthinuria. So my recommendation is you need to 1 week, or between 1 week to 1 month after starting treatment with allopurinol, just do an abdominal ultrasound, complete abdominal ultrasound, and urinalysis. And then after every 3 to 6 months, and doing the same thing, urinalysis and ultrasound follow-up. Remember, the abdominal ultrasound, you need to check all the urinary tract, because you can have xanthinuria in lower urinary tract, upper urinary tract, so it's very, very important. And if you have xanthinuria in these cases and they're receiving allopurinol, I think you should consider a low purine diet, or and reducing the dose of allopurinol. Many times, or most of the time, this strategy it's enough to decrease the xanthinuria and control the potential problems that you can have. And I think I'm finishing here. I'm ready to take any question. Thank you very much.
Yes, We are at the end of the webinar. So many thanks for the presentation, Luis. It has been really, really interesting. And well, we have received several questions and we will answer them in a few minutes. Thanks for being here again. So, well, before starting the first question, I just want to remind all people who are following us that once we finish the broadcast, you will have available here in the description of the YouTube the presentation that Luis has offered you, and you can download it for free. So now we'll start with the first question. The first one is about the urinalysis and the calculation of pH. And the question is that if there is a time of the day that it's more suitable to analyze the pH of urine, or it doesn't matter.
So I think it's a very good question. I think for consistency in the pH results, I tend to recommend to obtain the urine always in the same way, fasted, and with the same amount of urine, around 5 to 10 cc's. We know that the first urine in the morning is more concentrate, and that could affect. So I don't tend to use the first urine in the morning. But I think it's not clear how many or when you have to check this pH.
So, well, continuing on this topic, then you recommend to take more than one sample or just one to determine the pH of the urine?
I tend to use only one. However, sometimes when you have a result that is not, it's rare, it's not clear, or I tend to repeat 2 to 3 different measurements because sometimes the pH is affected for other problems or other situations, like if you have an infection, if you have fasted. So I tend to repeat more than one when I don't have a result that is that's or the result that I was expecting.
Thanks. We have another one that it's about other issues. In fact, well, you have discussed castration as an option in some urologists, but the question is that if castration would serve as a preventive method or not.
I think you should not castrate just for prevention, um, only in cases that you have cysteine or you have a high prevalence of cysteine, or you have a patient with cysteine urolith or urolithiasis. I tend to recommend castration. In other situations, I don't tend to recommend.
Okay, thanks. And the next one, it's about the diet. So you mentioned the diet in the, for example, in the STRUVITE stones, but in general, the question is that if do we have to maintain the diet when we have already dissolved the urolith or not?
I think it will be depend of which type of urolith you have. When we are talking about STRUVITE, you should not maintain the diet if it's due to an infection. So you only need to maintain the diet 4 weeks after you have dissolved this stone. But in other situations like cysteine, calcium oxalate, urate, probably in most of the cases, you need to maintain this diet during the rest of the life of the patient. So I think you have to think the most of the patient will need this diet forever or for the rest of the life, but in other cases not, like estradiol or allopurinol induced.
Thanks, Luis. Well, we do not have enough time, so we have to finish the webinar here. So many thanks for being here with us, Luis, and thanks for your presentation. And well, for all attendees, thanks for connecting with us, and we will see you soon in the next webinar. Thanks and goodbye.
Thank you very much. Goodbye.